Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about infantile hemangioma. Definition: an infantile hemangioma is a benign proliferation of blood vessels in the dermis and subcutis. The vascularity imparts a red, blue, or purple color to these lesions depending on the size and depth of the proliferative vessels. Incidence: infantile hemangiomas are the most common soft tissue tumors of infancy, occurring more frequently in female, premature, and white infants. They are likely to be brought to the attention of a physician because of their rapid growth or cosmetic concerns. History: most arise in the first few weeks of infancy. Infantile hemangiomas are usually asymptomatic except when they ulcerate or cause local obstruction, fortunately an uncommon occurrence. Physical examination: superficial infantile hemangiomas have a bright red color, whereas the deeper subcutaneous forms have a bluish hue. Mixed infantile hemangiomas are bright red dome-shaped nodules. Types of infantile hemangioma include superficial or strawberry, subcutaneous or cavernous, and mixed. Differential diagnosis: in contrast, vascular malformations or port wine stain, lymphangioma, circumscriptum venous malformation are generally present at birth and do not regress spontaneously. Rapidly involuting congenital hemangioma or ridge is present at birth, rapidly involutes by 1 to 2 years, and is GLUT1 or glucose transporter isoform 1 negative on biopsy, in contrast to infantile hemangiomas which are GLUT1 positive. Non-involuting congenital hemangioma or niche, which is present at birth, has superficial telangiectasia, gradually enlarged as one age, is GLUT1 negative, and usually requires surgery. Infantile hemangioma: in photo A we can see reddish blue soft nodule, and in B, in dermis, we can see focal proliferation of blood vessels and endothelial cells, and in C we can see rapidly growing hemangioma that requires systemic treatment to prevent serious complications. Laboratory and biopsy. A biopsy, if done, reveals a marked increase in the number of blood vessels, many of which are dilated, and an infantile hemangioma has GLUT1 positive staining. Therapy. Observation is the most appropriate therapy for many infantile hemangiomas, although these lesions grow out with the first year of life, and during this time the parents will need repeated reassurance. They usually involute spontaneously out with the ensuing years with a good cosmetic result. For ulcerating large head and neck or groin infantile hemangiomas, a therapeutic intervention may be necessary as vision, respiration, or a good cosmetic result may be compromised. Therapeutic options include systemic propranolol as the first line of therapy, topical temolol, intralesional and potent topical steroids, plus dye laser and surgical excision. The conclusion of therapy for infantile hemangiomas: initial therapy, no need therapy, but in the case of need, topical temolol 0.5% or high potency topical steroids is choice, and alternative therapy include propranolol 1 to 3 mg per kg daily, divided twice daily, and steroids 3 to 5 mg per kg daily, laser, and surgery. Cause and complications. Infantile hemangiomas often increase in size with the first year but then subside spontaneously, so that by the age of 5 years 50% are involuted, and by the age of 9 years 90% are involuted. Some 20% have residual change including scarring and fibrofatty tissue. Depending on their location, large subcutaneous or mixed infantile hemangiomas may cause functional compromise of neighboring and underlying structures, example the eye, ear, or oral pharynx. Hemangiomas occasionally ulcerate, become painful, and may be further complicated by infection. In infants with numerous hemangiomas or diffuse neonatal hemangiomatosis, internal organ involvement should be suspected. This rare syndrome occasionally leads to death from high output cardiac failure or compromise of an affected vital organs like liver, spleen, and intestine. Note, most infantile hemangiomas involute spontaneously during childhood. Pathogenesis. Although the pathomechanism of infantile hemangiomas is unknown, a localized proliferation of endothelial cells and the supporting stroma, resulting in a cellular mass containing increased vascular channels, suggests the importance of angiogenic growth factors. Clinical case: a 3-month-old female infant is brought by her parents because of a bright red raised lesion on her left cheek. The lesion was not present at birth but appeared at 2 weeks of age and has grown rapidly over the past months. The baby is otherwise healthy and feeds well. On examination, there is a well-defined soft bright red plaque measuring 2.5 cm on the cheek that bleeds partially with pressure. No ulceration is seen. Which of the following is the most likely diagnosis? A. Port wine stain on nevus flammeus. B. Infantile hemangioma. C. Congenital melanocytic nevus. D. Pyogenic granuloma. And E. Vascular malformation. According to our explanations, the correct answer is B, or infantile hemangioma. Explanation: infantile hemangiomas are common benign vascular tumors of infancy. They are absent at birth, appear in the first weeks of life, and go through a rapid proliferative phase followed by a slow spontaneous involution. They are typically bright red, raised, and soft or strawberry hemangioma. Differential diagnosis points: port wine stain present at birth and are flat and does not regress. Vascular malformations present at birth and grow proportionally with the child. Pyogenic granuloma is a rapidly growing, friable lesion that bleeds easily, and congenital melanocytic nevus is pigmented lesion and present at birth. Okay, this was an explanation about infantile hemangioma. Thank you for your attention.